Okay, so good evening, everybody, and welcome to this final roundtable discussion of our COVID-19 group. And yeah, so I first would like to explain how it will work. So I will first say a few words about this year, and then we have a little film with the worldwide data of the spread of COVID-19. So we can nicely see how the disease did go around the world this year. And then we will have individual presentations by our invited speakers. And then I will ask some questions into the round about, well, certain developments that happened during the year. And then finally, we will have a general discussion where everybody just can share, certain observations or questions that have occurred during the year about the disease. Okay, so yeah, it was an exciting year, I guess. Everybody was for sure thinking it will be a very different year in February or in January. So we heard the first news about COVID-19 happening in China, but I guess for somebody in Europe especially, that was at the time very far away. And it was then surprising actually how quickly this did spread all over the world. And so we had this first wave in spring. We had quite a few policy measures related to that. And I think especially in Europe, there was, of course, this story about Italy that I think was the most drastic thing we have seen in the early epidemic in Europe. And then somehow I think, especially also, I mean, that is the European perspective at the moment, we had things calming down a little bit over summer. So I think that was also interesting because of behavioral changes we will discuss later. Maybe people have relaxed a little bit too much during that time. And now also in Europe, but also in other places, and here I should mention the US, the disease is now really going very, very strong. However, there is one little hope, and that is that 2021 will have successful vaccination strategies all over the world. But how successful they will be is still open, I would say. So we should discuss that as well. Okay, so let me now go to the screen sharing and remind everybody with our little film about the spread, about the precise spread of the disease. So, yeah, okay, so what you will see in this film will be the incidence rate. And you should, of course, be aware of the color coding. Is that, can you see that? Yeah. To the right. So red is not the most dangerous. So black is the most dangerous, I should remind you. So let it run. I will maybe stop at certain points. So now we are in January. The disease is not too much around yet. Everything is green. Now it's March. Now it starts. So let me just stop for a second. So that is end or 2/3 of into March. So that's 21st of March, 2020. You can see here that the disease has arrived in Europe. So here you see red in Spain and in Italy. And you can also see a little bit that, for example, in Iran, it has taken up. So let's continue. Yeah, now here we have April. Now you see that the disease has reached the US at that point in time. So it's now a US and a European disease. Okay, so we go into April, now May. Let's maybe stop in May. So you can see that there are now problems arriving in South America, but mostly actually at the west coast. So Peru and Chile, you can see. The US really takes up. You can see also Russia has now problems. It has definitely arrived there. And you can also see in Europe that now the UK has a problem for the first time. Now let's continue. Yeah, now you hear in June, you can see Brazil has a massive problem suddenly. Now whole of South America is really affected. In Europe, it looks relatively good now in summer. But now in September, the second wave starts. South America is still having problems. The US throughout the time. Now it's picking up in India as well. Yeah, and now you can see we are now in November, and the US and Europe really have a massive problem, much worse than in the spring first wave. Yeah, so this was the incidence rate, not R0. We also have a film about R0, but you can see, I think, the wave-like structure better in the incidence rate. Okay, so I stopped screen sharing. And yeah, now I would like to go to the individual presentations by our speakers. So let's start with Chris Bauch from Canada. Chris, we cannot hear you.
Okay.
Yeah, now, yeah.
Okay, sorry. Yeah, so I just have 3 slides to share. The first one is an update on the most recent happenings, and of course, we're having a quite large second wave with a much lower mortality rate. That's one big change. The other one is that vaccination has started last week in Canada with the Pfizer, BioNTech, and soon with Moderna. And the recommendations are in the stage 1, they're going to focus on vulnerable age groups, elderly, and then also healthcare workers. And finally, adults in Indigenous communities. So that means First Nations people in Canada who historically are disadvantaged and have serious health problems. And then in stage 2, it will broaden. I think Canada, because it was hit by SARS in 2003, was a bit more sensitive to things like pandemics. And perhaps this is one reason why we secured or pre-ordered more vaccines per capita than anybody. to the point where we have now 8 doses per person. So you could vaccinate people with a full course of 2 doses 4 times if you wanted to. And hopefully we'll be able to donate those excess doses to countries that need them once Canadians have been vaccinated. And in terms of our modeling, well, I talked a bit about the vaccine allocation problem before, and our model has been expanded to include the second wave here. So you kind of see the data and the dots in the model here showing the second wave. And what you also see in orange here is mobility data. And we noticed in the orange that there was a big change in the percentage of time spent at retail at the beginning of the pandemic, and then it very slowly ebbed down. And then when the second wave started again, there was only a slight increase in, I'm plotting it as positive, but it's really a negative and negative. There's an increase in amount of time people spending away from retail, but not as much. And so we've been updating our model to that. We've been doing some revisions. We've also got an interesting paper out on medRxiv now, talking about how we can basically use these digital contact tracing apps to do vaccine prioritization. So we know from these contact tracing apps who has more contacts, and the idea is to use that information to prioritize people who have a lot of contacts. And then we've been doing some applications of percolation theory to show that, you know, if you can target people this way, you can get big benefits in terms of reaching herd immunity threshold. In particular, if we compare uniformly vaccinating the population to these targeted strategies for 40% uptake, 60% uptake, or 100% uptake of the app in the population, you know, even if only 40% of the population takes it up, we go from a herd immunity threshold of around 33% to only 15%. So in other words, we can reach herd immunity with half the number of vaccines if we use these digital contact tracing apps. So that's currently on medRxiv and in review. And we're hoping that this approach might be rolled out in phase 2 when they've finished giving it to the vulnerable age groups, and now it's being given to the broader population. We should target those people who have the most contacts, and we can eliminate it much faster that way. So that's all I wanted to say.
Thank you very much, Chris. It's very interesting. Now let's go to Ronald Punafat in Brazil.
Hi, can you see my screen? Okay.
Not yet. Sorry.
Not yet. Sorry, we had this problem last time. There's a share button.
Yeah, now it's okay.
Now it's okay. Okay. Okay, guys. Thanks very much. Just a few words. Sorry, my first slide, of course, is really hopefully going to talk about some of the missing pieces of the puzzle that the media isn't, of course, be speaking about. I'm based in São Paulo, Brazil. 23 years in Brazil, so the heart of the hot spots. So what's happened since we last spoke? And I'd like to thank Professor Marcus for inviting me, of course. It was in August, and of course inviting me again to this roundtable. Okay, well, as everyone knows, we are in the second wave is in full swing, even though it's summertime in Brazil. So there's this theory that hot weather, of course, makes everything under control. Well, I can tell you, it's pretty hot outside, and the second wave is certainly alive and well, unfortunately. We also make a comment on social behavior. I would like to say, I'm pretty sure about this, to be honest, that we had compulsory municipal elections, which was on the 16th and the 29th of November. Okay, these are compulsory. Voting is compulsory in Brazil. These were like the mayors of the cities all over Brazil, and of course, that meant everybody had to go out and vote. Okay, right, fine, which is fine. But that wasn't really the problem, I think. I mean, just one day, go and vote, whatever. The problem was that the politicians that were in power, or even wanted to win the elections, did not really chastise antisocial behavior. Okay, so people are doing crazy things, going to the beaches in Rio, you're not supposed to, there's a law. but people were going to the beaches, and the government didn't want to appear heavy-handed because they wanted to win an election, obviously, right? So I think that election, which we had in November, mid-November, that opened the gates to bad behavior, and the genie was out of the bottle, and that was that, okay? So America talked about their Thanksgiving. We had a whole month of Thanksgiving in Brazil, sadly. So unfortunately, that was the biggest impact on social behavior, and getting people to behave again is a problem. Now, you may see Bolsonaro, our president there, I think 2 days ago, he came out vehemently and saying he's not going to take the vaccine, right? He says these things, right? And you have to understand, the world has to understand why he's doing this sometimes. I mean, Bolsonaro does not have power in Brazil over the states. The states have autonomy, okay? So he can just yell and scream and make his little comments, but he doesn't have power to shut down places in São Paulo. He doesn't have the power in Rio, okay? So sometimes he's a little verbal, but it's really posturing. He's doing that, right? Now, in Brazil, there are two types of politicians. There are politicians who want to rise up the ranks and become the president, like the São Paulo governor. He wants to be the president. He believes he can be the president one day. And then there are presidents who just, people like governors and stuff, who are just trying to stay out of jail. Sorry to be so rough, but that's basically it. So the guy in São Paulo, Doria is the governor, he's really trying to be president of Brazil. That's his ambition, right? May not happen, may not happen. So he has his coronavirus plan. He has an agenda. He has stuff going on. He has the coronavac signed up with the Chinese, right? Rollout plan. Life is good. São Paulo, all by himself, right? And that angers Bolsonaro, of course, because he sees this guy as his political rival. So when Bolsonaro is really behaving a little badly, it's really because he's trying to temper the popularity of the São Paulo governor. So it's a little political game going on there. And by the way, Bolsonaro is at an all-time high politically. He decided to throw money at the very poor in Brazil, and a lot of money, a lot of cash, like the stimulus bill in America, and it has paid dividends. So if you did a survey today, do you like Bolsonaro? Wow, he's certainly very, very popular, all-time high, even more than when he got elected. The fourth point is, believe it or not, Brazilian NHS, the National Health Service, is still hanging on by a thread, but it has done extremely well. No one expected this, to be honest. Thank God, things are going well with them. Of course, you may ask us to make observations. I'll say the big difference between, let's say, Brazil and let's say England, Europe, Germany, let's say, right? The national health system in Brazil has a very important safety valve. What's a safety valve? The Brazilians can go to a soccer stadium, like the Maracanã in Rio, and put hospital beds there, and they will stem the tide of this hospital, the lack of hospitals. They can do that. That really can't happen in Europe. That would be a national disaster. If London went to Wembley and did that, or now the Olympic Stadium, that would be, England would be considered a third world country. It would lose all its credit rating and everything. So I always say Brazil has the safety valve. If the hospitals are overflowing, we can go to the big open areas, build a field hospital for a couple thousand, and it's okay, right? And that's a big difference between the Western countries and, of course, and Brazil. We have this, I call it a safety valve, just in case, things get out of hand a little bit. Right. So what hasn't happened as yet? Nothing happened. The tracking of number of tests and results, not credible. Even the Ministry of Health has not even going to guess. So when you see these sites talking number of tests per population per day, forget it. Nobody knows, right? It's a complete guess. It's very, well, I was speaking to one of my friends whose mom was had coronavirus in a private center. And I asked him, well, did they ask her, like, who were you in contact with? Are you going to contact tracing, anything, an app? Nothing. So I know a Canadian colleague mentioned this interesting thing about contact tracing can really reduce R, even though the vaccination isn't 100% as yet, So that's quite an interesting comment. I have never seen anyone with an app talking about contact tracing. It doesn't exist, which is quite bad, of course. And the vaccine has not been approved as yet. It's here, they're testing it. And I would say in Brazil, there's a local FDA, which is called Anvisa. It's not helping. Even though it's been approved by Europeans, by the North Americans, the Brazilian Anvisa has to do their own tests. And they're not very quick about this, okay? So they're really not helping. And I think they're really shooting themselves in the feet. In this time of pandemic, you have to be a little more quick. The Americans approved the Pfizer thing very quickly. England did it, of course. Brazil is dragging its feet, unfortunately. So not looking. And Brazil has logistics. There are good and bad things in Brazil. We don't have super cold freezers, right? Maybe in the cities they'll have it, maybe one in Sao Paulo, one in Rio, but from a national point of view, the Pfizer drug isn't going to happen, right? The fact that they the CoronaVac, I think that needs a temperature of between 2 and 5 degrees Celsius that they can handle. Okay, so definitely, unless Pfizer moves their formula and has a new vaccine to make it don't demand these super freezers, it's not going to happen. And I'm sure a lot of other emerging markets will have the same issue as well. And so that's the thing interesting with the super vac thing. And so anyway, it's not ruled out as yet, unfortunately. The $1 billion question in Brazil would be, what's the time frame to get 60% of Brazilians immunized? I'm just making a comment that RT going over the plate completely unbridled is 2.5. That's why I got my 60%, but RT could be, of course, higher or lower. Whatever. Nobody knows, of course. I find it very interesting. The Economist has a site called Good Judgment. Very interesting. And they move this number every day, right? So you can go to the site, I put the site at the bottom, and according to The Economist in America, they believe it's around April to September that they're going to get the vast majority of people will be vaccinated. And of course, life is good there. But in Brazil, who knows? It's not going to be the American standards, of course. Sorry, one good thing about Brazil, believe it or not, there are other things here. In that there's a company that does syringes, right? It's a very big company. This phone the name today. Becton Dickinson is called. They can produce 1.5 billion syringes a year. That's their capacity. So in a way, Brazil is good from those sorts of things. Sometimes because it's the house of Latin
but I'm
America.
just listening. Yeah, in the background.
Okay, that's very interesting. So not
sure,
many the syringes. They have to import it. So you say Canada can buy all this stuff. Great for that. Happy for you. But to get the syringes and the valves it's not that easy. So Brazil is a country of scale. So that kind of works in our favor a little bit. So any good news? Not so much, to be honest. Struggled here to get these slides up. The stock market is booming. The driver is that is foreign investments have poured into Brazil the last 3 months. Okay, so the stock market right now is ahead of pre-COVID numbers. So I guess that's good. Okay, and on the left-hand side, I'm showing here. This came out today actually. PB is GDP in Portuguese. Okay, and looks at the GDP. In Brazil, had a very low year in Brazil, 1.4% GDP growth, which is not good. LATAM is quite low. But in 2020, this year, because of the economy is kind of free, to be honest, sadly, but it didn't contract that much. It's only going to contract 5.3% for the year, which of course is much better than a lot of Latin countries, sadly. But and on the right-hand side, from The Economist again, you can see I'm a fan of The Economist, talked about how vulnerable countries post-coronavirus. There was a long-term effects. So like 10 is like a terrible number, the worst. And sadly, the Philippines is up there with, the Philippines is really going to suffer, according to The Economist charts, post-coronavirus, right? And South Korea is going to go really well, okay? And you can see Brazil, because of the scale, because of the economy, because of, I guess, we didn't really shut down so much, to be honest. Brazil is almost like America. So in some ways, Brazil is apparently expected to do very well in Latin America after all is said and done. Hence, all the money is coming to Brazil, and hence the stock market is booming there. So that's some good news. As I said, I was struggling. And that's basically what I wanted to say today about Brazil. Thanks very much, Marcus.
Yeah, thank you very much, Ronald. That was very interesting about the situation in Brazil. So now let's go to England, to Jane Hutton.
realize I had muted myself and then I'd lost my, okay, can you see that?
Yeah, we can see it. It's
Good.
perfect. Yeah.
Okay, so just a few, nothing like as sophisticated as the other ones we've got. This is looking at whether by age, getting into hospital and how quickly people either die or leave.
Mhm.
There's about 30,000 people in the UK, majority in the older age group. So basically the picture is what we're familiar with, but actually something that's very different from what would normally be called a pandemic, where you wouldn't have this very, very strong age profile that's saying basically the over 80s, you know, nearly half of them will die. And indeed the 70s to 80s of those admitted with COVID. Okay, this doesn't allow for changes over time, is getting up towards a 50%. But actually the younger age groups, you're getting very little. Now, if you go for the male and female, not only are more men getting COVID, getting into hospital, but the death rate is sitting quite substantially above the death rate for women. I'm not sure anybody's really been able to answer that yet. In the UK, there's been a lot of discussion about obesity associated with higher death rates. And what I was interested in was, well, what's the quality of the data? Actually, almost half the people, the records, have got missing data. And you find people will say, well, you know, we sort of imputed the values, which is all very well, but, you know, these values just don't make sense. The idea that 22% of people are obese, or even 24%, overweight and borderline obese, the numbers just don't add up. And what I find even more worrying is what happens if you compare those classifications. Well, you're only getting agreement on obesity 3/4 of the time. So this is body mass index, which one hopes is perhaps slightly more reliably indicated. But if that's above 30, you've only got a 3 and 4 chance of actually being recognized as obese. And you can see that, you know, basically you're not going to be clinically recognized as obese until you get to be very, very heavy. So you don't know what's going on, let alone the fact that we've got most of these just unknown. Even people who should be visibly overweight and at least count as borderline, they're just not getting picked up at all clinically. So I'm afraid I got interrupted by other work, so I haven't done anything more than this. But what I would also mention is that, which is why wrong website. Sorry, I've got to, I do dislike it when you can't get at things. What I would recommend is the COVID task force on the RSS website. It's got quite a lot of information. One thing of particular interest to me was the diagnostic test, because one of the things we still don't have is actually an agreed definition internationally of what COVID is. Mm-hmm. So of course, all your statistics, which are very valuable, but they rely on data which knows what COVID is, which is not agreed. And all the diagnostic tests, a lot of them have been really very problematic and not very good standards. So it's more a work in progress than anything else. But my colleagues in the RSS, and I imagine elsewhere, are trying to work hard to improve the quality. And wearing another hat, that for me is good news, because actually I also work quite a lot in statistics and the law, where, you know, you decide whether people are drunk driving, things like that. And that isn't often very done with a high quality measurement. So the positive side might be that we might get a much clearer standards for when a test is worth using and when it may just be diverting money and not actually achieving anything.
Mm-hmm.
Okay, thanks.
Yeah, thank you very much, Jane. That was a very interesting view on the statistics side of things.
Yeah.
And yeah, now I would like to go to I think to Nelson Onyango in Kenya.
Thank you. Let me share my screen. Okay, so I hope it's visible from your end.
Yeah, it's fine.
Okay, thanks. Let me first introduce myself. My name is Nelson Onyango. I teach biostatistics at the University of Nairobi in Kenya. And approximately 10 years ago, I was a PhD student at the Technical University of Munich under Professor Johannes Muller, who is part of the team. So I'm very grateful for the invitation. I think I was supposed to attend earlier, but I was not able to make to attend the previous meetings. Okay, so I know that the time is limited, so maybe I could just go over. I have a couple of slides, but I was reminded that the time is not quite a lot, so I will just basically run over them. Then we can be able to see what to stress later, or maybe if there are some questions. Yeah, so anyway, my source of data is mainly from the Ministry of Health. We have an emergency operations center that actually collects data and gives situational reports every week. And then we also make use of the data from the Johns Hopkins University Center. They have live data that is updated almost on a daily basis. So for Kenya, we reported the first case in March. And actually, by the time I started writing this report, then around 14th of December, we had reported around 91,000 cases, confirmed cases, out of which about 1,500 mortalities were reported. So about 1.7 case fatality rate from that. So this is, of course, just a general picture that in as much as countries were reporting figures like 200,000 by around May, most African countries were still reporting almost 10,000 and below figures. But this is probably not because we didn't have COVID-19 cases. Maybe there are other factors like maybe the extent of testing that may have contributed, but for quite some time, we were reporting very low cases of COVID-19. Yeah, currently the situation stands like demonstrated here. These are new cases that are being reported on a weekly basis. The graph shows weekly reporting. And we more or less see this second wave also coming up. It's probably not as strong as maybe some parts of the world because we can see around 6,000 such new cases that are reported roughly in a period of a week. But that is clearly a second wave of infection after the first. Maybe the reasons are not quite clear, but if you look at my graph, I'm not sure if it is so clear. Around October 17th, the government was already satisfied that the curve had flattened, and they decided to even reopen schools because initially they had closed schools and so on. So I guess probably people thought that things are now better. So let us go back to our usual lifestyle and then maybe the second wave. But we have majority of our cases asymptomatic. If you look at my graph, the orange is asymptomatic, the blue is symptomatic. So most of the cases that we are reporting are basically asymptomatic.
Mm-hmm.
Of course, this is almost similar to the curve around the world. I picked on some 4 countries in Europe, not to demonstrate the figures because probably you are familiar with them, but just to try to see the face. For example, in Kenya, we probably had this second wave starting around 21st of September, probably. But if you look at the situation in Europe, it was something around August, early August, when the second wave started. So ours has a lag of about 1 month even at the initial case of spread. Again, probably not because we don't have cases, but probably we react after a little bit of a while to the development of the disease. So my main intention was to try to get a few parameters based on the current data. For example, what is the prevalence, what is the attack rate? And if you compare probably just Kenya and South Africa, because South Africa seems to have more advanced figures, I think because they have more cases of testing and so on in Africa. Most African countries are not reporting significantly higher figures, maybe because of testing. And still, even South Africa does not seem to have high rates. For example, an incidence proportion of about 1,400 per 100,000 by current figures. So still quite low figures. We are not sure if that is the true situation. And a lot of policies, measures have been put by the government. In fact, I tried to summarize the dates when the government did what, from lockdowns to night curfews, to blocking international flights. And now we are again back to local flights being allowed, and even international flights have been resumed. And schools have also reopened, more or less. So despite the second wave, I think things are back to normal. Not too much restriction as at now. Looking at the first 100 days, you could see the effect of some of these measures. Like when the flight bans were made or night curfews were announced, the period after that, maybe a week after that, had some sort of low figures being reported. But then it could rise again up immediately after, probably when people again lose their strict measures and so on. Lockdown, for example, also made some impact and so on. But particularly mass testing, I didn't have the graph after mass testing because it dwarfs all these other interventions. But after mass testing, there was a big change if you actually did the time series change point analysis, because then that is the time they started seeing the number of cases. Yeah. So mortalities also have been rising with the increase in number of new cases. But again, apparently we report around maybe on a maximum 100 cases per week or something like that for mortalities. But this is clearly again a second wave, even on the mortality side of the infection. So recovery rates, we are reporting about an exponential growth in recovery. And why I was doing these things is just to try to get some figure for a rate, maybe something that might be useful when you go into the modeling aspect for the disease. So reporting a recovery rate of about 0.04 on a daily scale. So that more or less translates to about 25 days of viral shedding for COVID-19. I'm not sure the exact period of viral shedding. I didn't check the biology, but this rate here looks like around 25 days of infection. So I think I want to summarize those low figures by actually case of underreporting. The government has a target, this red line here, of about 6,500 tests per day. But we have been falling much, much below that. Of course, right at the beginning, the figures were much lower. But right now, the government has really tried, and just around mid-November, we reported close to the target, 6,500, just above the target. But the reporting has been very low, lab testing for COVID-19. So probably that has its own effect on, I think, a number of parameters. Sometimes when you do underreporting, the transmission rates, fatality rates, and so on are not reported correctly. And I think there are papers that are trying to understand this kind of a situation. So majority of cases that we are reporting are the middle age, 30 to 39 there. Children below the age of 9 are very few, actually about only 3,000 if you look at both men and male and female. Only about 3,000 out of about 100,000 that have been reported so far, the confirmed cases. So this is clearly a disease that has spared children, particularly from our side of the world. And then majority are males. The females, about 37% to 63 male percentage. So one thing that the government is getting concerned about right now is that health workers are reporting so many cases. Yeah, although we have reported only about 32 deaths among the health workers, but you can clearly see that the number of cases that are being reported among health workers in both the waves is clearly a big number, 241 per week. So something needs to be done to protect our health workers. In terms of contact tracing, the red section of this curve indicates, and these are every region, geographical region within the country. The red part indicates the tests that are done, contact tracing that is done 8 to 14 days from the time one case is reported. So the green part would have been below 3 days. Not many cases are traced within 3 days. The yellow part is 4 to 7 days, and then the red part is 8 to 14 days. So that seems to be the dominant period. But this is because contact tracing is based on human recall. It's not, there's no much technology. I don't know if there is any telephone app or something that is helping to improve on contact tracing. And of course, human recall is biased in many ways due to forgetfulness or sometimes just attitude. So that's why it takes slightly longer to get the contacts. Vaccines, we still don't have any approved, but the government is taking track of the vaccines that are being developed. And one of them that they have identified with is the AstraZeneca, which is actually developed by the Oxford University. Of course, for the same reasons like Brazil, Pfizer is a bit, of course, one of the best, and it has already more or less gained prominence. But because of the conditions under which it has to be stored and so on, I think that is a problem for the African countries. So maybe they may go for something they can manage. Yeah. So I didn't yet model, but I was just suggesting that probably because of too much underreporting, models that more or less want to demonstrate the African situation need to capture a bit of that extent of underreporting, like one of these papers that was done by some authors in Italy. So in terms of behavioral change, a lot has happened. Of course, most of these being government policies. But for example, right now, public places like bars are not opened anytime later than 9 p.m. So the government is more or less strategizing with banning night curfews and night movements. Then face masks is a must. Places of worship, for a long time, the churches were closed, the mosques, the places of worship were closed. But now they've allowed them back with restriction on the numbers. Around a third only can attend in the seating capacity. Air travels are back, but they were banned for quite some time, but now they are back. Schools have been closed for quite some time, and no commercial trucks are allowed to cross the borders because they assume that that is a risky group. Yeah, so I think that is basically what I had for today.
Yeah,
thank you.
Thank you very much, Nelson. That was very interesting. Yeah, and the situation is really a little bit different, I guess, to Europe, and we will discuss it in a moment. But first, we go to Sunita Reddy in India. So I think Sunita doesn't use slides, but will talk us through the situation in India.
Good evening, everyone. Thank you so much, Professor Marcus, for giving me this opportunity. I'll be speaking from public health perspective, since I'm teaching public health. I'm an anthropologist and teaching public health in Jawaharlal Nehru University, New Delhi. And I work on disasters and been looking at pandemic for some time. First of all, I'll briefly give about public health perspectives in India and how healthcare services are arranged in India with a lot of budget constraints, and then compared to neighboring countries, further use of web-based apps during COVID, and finally, very briefly about the vaccine preparation, which is ongoing. As you all know, India is the second largest populated country, And India has a robust three-tier public health service system and equally robust private sector, providing primary, secondary, and tertiary care to 1.3 billion population, which is a huge challenge given a limited resources. India's hospitals are currently short of doctors, medical equipment, and ICU beds, with authorities struggling to cope up with an unprecedented health crisis. A surge in COVID 19 cases has overwhelmed the health systems. Many makeshift arrangements were done in the beginning. The Global Health Security Index 2019, which measures countries' pandemic preparedness, ranked India at 57 out of 195, and China and Italy with hotspots fared far better. The response to this emergency was and continues to be steered by India's public healthcare system, a system that has been sidelined and plagued with long chronic underfunding for all these years. India's public investment in healthcare is one of the lowest in the world. India allotted 1.28% of GDP as health budget in financial year 2018 as compared to national target of 2.5. However, as a result, there is only one government doctor for every 1,445 Indians, much lower than the WHO's prescribed norm of one doctor for 1,000 people. The National Health Profile 2019 highlighted that there were 7,13,986 total government hospital beds available in India, which is about just 0.55 beds per thousand population. For comparison, Sri Lanka, which is neighboring country with a better health system and similar GDP per capita, has 3.7 beds per thousand population, and China has 4.2 beds respectively, while WHO recommends 5 beds per thousand population. So you can see the lack of resources and especially the infrastructure, which is very less. The Integrated Disease Surveillance Program, which was once considered to be India's first line of defense against epidemics, continues to struggle for manpower and resources. India has a robust three-tier system, but as I said, it lacks resources. And in March, Prime Minister announced rupees 15,000 crores for improving the health care system. However, most of this money was spent on importing safety and PPE equipment, testing kits, ventilators, and other such items which were urgently required to combat uh, COVID-19 outbreak. It was not enough or even designed to address the historic gaps in public healthcare sector. India needs a greater push to build back a better health system as part of its emergency preparedness. Because public facilities are inadequate, citizens frequently turn to private healthcare providers, bearing almost 80% costs out of pocket expenditure. Reports of overcharging, huge cost for ICU beds were witnessed, and some governments, like Delhi government, made efforts to cap the prices of the private hospitals. Now, the frontline healthcare workers visited hundreds of households repeatedly during the pandemic to ensure that every possible case is identified as early as possible in few states like Andhra Pradesh, Delhi, Kerala. There is a need for increasing investment on health services to strengthen them and make them fit for future challenges. We should also accelerate long pending initiatives for health systems reforms, future challenges, and the central goal of National Health Policy 2017 is to accelerate universal health coverage. Um, Looking at the COVID response, we could see that vast death toll and confusing data flows have exposed the limitations of modern medicine. No one diagnosis is effective. Symptoms are too inconsistent to get a fix on the disease. Most of the information about their development is cloaked in secrecy. The side effects are not fully known. There is no drug yet to counter the virus. In this context, new revolution is sweeping Indian health landscape, and that is the alternate healthcare medicine, which is already there for ages in India, with an acronym of Ayush, which all of you know: Ayurveda, Unani, Siddha, homeopathy, and yoga. Ayurveda, Siddha gaining prominence in this COVID pandemic, especially for preventive measures to boost immunity, and drink kada. Kada is a kind of decoction. The Ayush Ministry has documented the impact through Sanjeevani mobile app among 1.47 crore people. Almost 85% respondents have reported use of an Ayush remedy as prophylaxis treatment of COVID-19. Of that, 89.8% reports benefits from the practice of Ayush advisory and 79% reported overall good health. Now, coming to some of the reforms which have been taken place in the middle of pandemic, the government of India has taken several measures to contain the spread of pandemic and also to mitigate its social and economic impact. On 26th March, 1.7 trillion Indian rupees relief packages were announced by the finance minister. On 15th May, the Prime Minister declared a COVID relief package of 20 trillion rupees. On 14th November, 2.65 lakh crore comprehensive stimulus package was announced by Finance Minister. Under all this pandemic situation, India is witnessing huge reforms. Some reforms are questioned and debatable, like the 29 labor laws being simplified, amalgamated, and rationalized into 4 labor codes, providing effective social protection to the migrant workers through national portability of ration cards. That is one nation and one ration card for food security and public distribution system. The rural sector has been provided support through NABARD and additional liquidity of 27 billion US dollars in the farm sector, and by way of increased allocation for Manrega, a program which is for wages, work for wages. And current new farm laws are being debated, and farmers are protesting on the borders of Delhi, where it is believed that big corporate houses will dictate the terms and without giving minimum support price by the government to the farmers. Now, these reforms at the time of disasters reminds me of the book which I read of Naomi Klein, The Disaster Capitalism and Shock Doctrine, where she talks about all the agendas which are pushed through in the state of shock, be it a disaster, war, or even conflict. So one can look into these aspects in similar light, and there are a lot of critical issues to be discussed and debated. The finance minister has further announced medical insurance cover of 5 million per healthcare worker. About 2 million health services and ancillary workers will benefit from such insurance schemes. But critically speaking, such insurance coverage is limited, and often the real needy people and the poor are left out. Uh, Coming to technology and Arogya Setu app, which was developed post COVID-19, when the pandemic started in India, the Union Health Ministry launched Arogya Setu app to keep a track on infected patients and area-wise concentration of COVID-19 infection. The Arogya Setu app is a COVID-19 mobile tracking application developed by the National Informatics Center. The app is available in different Indian languages. It detects and tracks the user's movement with the help of GPS and Bluetooth sensors. This information is then cross-referenced with the Indian Council of Medical Research database, where positive cases have been reported. Whenever there is a match in the location, the user gets a prompt. The app also has a self-assessment feature of users at risk of COVID-19 to report symptoms. It is the world's most downloaded contact tracing app. The IT ministry has also launched the COVID-19 feedback app and uses it like a survey tool to gather information from users about any treatment or tests may have gone through. This helps the government to identify areas to improve testing and treatment processes. The Survey of India has created an app called Sahyog, which means help or support, which will complement Arogya Setu for contact tracing, public awareness, and self-assessment objectives. Sahyog will collate data collected at the state level and geotag it to the Survey of India, which can analyze this information as database grows. The objective is to help the government improve the response system. Now, various trace and track efforts have been done by various states. One common and important concern for trace and track efforts is the lack of involvement of epidemiologists in such technological initiatives or in the development of such apps. The app's greatest limitation lies in the number of downloads. For the app to work properly, it is essential that more people download the app. Till now, there is no concrete data or study about efficiency of track and trace efforts. It is important to remember that India does not have yet a data protection law. Now, finally, a few minutes I would like to talk about the vaccination drive. The Union Ministry of Health has sent its operational guidelines to states and union territories for the distribution of vaccine as and when it becomes available. Now, the government has launched a new app, CoWIN20, which will be the go-to app for COVID-19 vaccine distribution. All information on this platform will be updated in real time. Following the footsteps of Union Health Ministry, the Mumbai Municipal Corporation, BMC, has decided to develop a real-time monitoring COVID-19 mobile application to regulate the vaccination process for 2 crore population in Mumbai. The document, which has been shared with all states, says that only 100 people per session at each site per day are likely to be vaccinated against COVID-19. However, the number of people per session might go up to 200 logistics which can allow. And finally, the states and union territories can fix the dates for vaccination. Conduct of vaccination process similar to the election process, the health ministry document says. A vaccination site should have 3 rooms or areas, including a waiting room, vaccination room, and observation room. According to health ministry's plan, the COVID-19 vaccine will be the first given to healthcare workers, almost 1 crore people, frontline workers, almost 2 crore, people above 50 years, 26 crores. After this, vaccines will be given to those below 50 years of age who are suffering from chronic critical illnesses, which is again 1 crore, for a total of 30 crore people in first phase planning. Based on the voter list prepared in the Lok Sabha elections and assembly elections, people above 50 years of age will be identified. Now, social media is, however, full of information on the side effects of the vaccine and also the hurried nature of finding one to prevent COVID-19. So there are a lot of issues to be debated here because there's so much of uncertainty and disbelief about the whole vaccine, which has come out so quickly because all these years vaccine took time. The clinical trials used to take a long time. So with all these anxieties, people around are not very clear, and most of them are saying we'll wait and see, and they are saying that let it be tested first properly, and then we'll go for it. And especially if it has to go to the healthcare workers, and they are much more aware of the side effects of vaccine. So these are being debated right now. So I'll stop here, and if there are any questions, I'll be glad to take. Thank you.
Yeah, thank you very much, Sunita. So yeah, so we should go through the questions now. So I will explain and ask a question to each of our topics we have today. And well, I would like to ask you to keep it relatively short. So the first question is again about behavioral changes. This, of course, can be discussed in different ways. So the first behavioral change, I think, is becoming aware that COVID-19 is around, and then having information about how dangerous it is actually. That was, if you remember, in spring, that was a big issue because people were not really sure how dangerous this was. And then another behavioral question is, of course, COVID fatigue. So how much did you observe that in your countries, that people just became not careful anymore after some time because the pandemic was going on for far too long. There are also issues, of course, with respect to the economic situation. I think this would be interesting in Brazil and in Africa and in India, you know, how people are actually forced for different behaviors due to economic problems. So you see what I would like to ask with this question. So it's a general question about your observations of how the pattern of behavior changed during the pandemic. So unfortunately, Chris had to go. It would have been interesting to see how that worked out in Canada. But then let's go to Ronald. Do you have any comments on this?
Well, in Brazil, we really never had a really hard lockdown, to be honest. Okay, so not like as you see in let's say Germany or New York and things like that. People are kind of left to their own devices, to be honest. There's lots of data. Every day the newspapers shouts the number, of course, what's going on, the hospitals. So the news, of course, are telling you, you know, really stay at home, behave yourself, you know. But really, it's not really happening, to be honest, you know. Even like the bars are open and things like that. From a behavioral economics point of view, I would say sadly it's something I read again. Once again, the Economist is going to quote it. They said that one thing with Japan has its issues, of course, but they said that it's a very homogeneous society, and they say this could be their strength because when they decide to do something, they do something as a group. And Brazil is not homogeneous, right? So if you know Brazil, the very south of Brazil, it looks like Germany, I guess, and the very top Salvador, you know, is what you imagine Brazil is tropical and everything like that. And it couldn't be further apart. So unfortunately, I think, and I would say, not any Americans in the audience, America isn't very homogeneous. America is very heterogeneous, of course. And I think that this is an issue from a heterogeneous country, as Brazil is. Everybody's doing their own thing. And, you know, sadly, what can I say? It's there, you know. Sorry, there's something that our colleague in Kenya talked about, mass testing. That hasn't happened in Brazil, not even close, right? Which I think is quite embarrassing, to be honest, you know, like really mass testing, you know, pooling, you know, do something like that. Check out the positivity rate even on a Saturday or Sunday, nothing. So I think that it's quite appalling, actually, to be honest, that there's so many boxes that you can tick, and, you know, a lot of boxes just haven't been ticked, you know, so it's quite poor, to be honest. I really can't say. I don't know. I don't even know where the future is, to be honest. It's quite appalling. But Brazil is quite stratified in let's say social class systems. So in certain, the very elite in Brazil, they're behaving themselves, right? They're really in their country homes. They don't see them. They're hiding, and they can do it, right? And of course, the poor can't. And public transportation, of course, is used and things like that. And that is an issue, of course. But they need, Bolsonaro, the president, has thrown money at the poor, billions, okay? So that has helped a little bit.
And without asking for behavioral changes, I guess.
Yeah. So the poor are doing what they're doing, and I think the rich are really, they have the luxury of social distancing.
Yeah. Thank you, Ronald. That was very interesting. Jane, maybe one specific questions about the statistics of behavior. Do you think there would be anything measurable, or how would you try to measure changes in behavior, for example, in Britain? Oh, your microphone, Jane, is, I think.
Yeah. I think some of the ways that have been done by using Google data would probably work, or just sheer observation. Somebody did comment that, picking up Ronald's theme, the people who are less likely to observe lockdown are the people who are poorer. They can't afford it, and they're the healthcare workers. I think a lot of the messages have got through, and when people aren't following them, it's a deliberate choice, not having not heard about them.
Yeah. Yeah. Thanks, Jane. Yeah, let's ask Nelson, especially, so is there a problem with respect to, economic, let's say, support? Because I guess people don't get as much support as if they have to close shops and things like that, as we have it in Europe, for example, or also in the US or in other developed countries. Did that make a big difference in Kenya?
Yes, for sure. I think I can say that in the economic aspect of things, COVID really created a big impact for African countries. At Kenya, for example, because most businesses had to close, particularly because people were not interested in buying things, for example, luxury things. And people only went for very important things. So most businesses, for example, beauty shops, had to close.
And they didn't get any support from the government, I guess.
No. I don't think there was any deliberate attempt to compensate business people where they probably businesses were interfered with. People lost jobs, maybe big numbers. I don't have the statistics, but you could be talking of 30% plus of the workforce that had to be laid off because companies closed more or less. Yeah. So I think in terms of economic effects, that was really felt. Yeah.
Yeah, and maybe I would like to ask Sunita again about this behavioral change in India, about the migrant workers. That was very much in the press. Has that problem been solved in the meanwhile?
Yeah, Marcus, actually, if you look at the job market, as Dr. Nelson said, that here in India also it's been a huge loss. Most of them lost their jobs, especially the unorganized sectors. And even the organized sectors, they were laid off or maybe 30% cut in their salaries. So the complete lockdown, those 3 months was a major loss. So as soon as the unlocking started, people started working. I mean, many of them started working in different sectors. People have started going back to their work. Migrants who have gone back home have started coming back to the cities. Even we don't have proper data to support how many are coming back and how many, because rural India still doesn't have those opportunities for them to work. And within these 6 months, not much has been done to provide work for them, except for the work for wages, which was increased. But that is not enough for the migrants to stay back. So most of them are returning back. However, schools, colleges, and universities are still closed, and most of it is happening online. But again, online education is not available for most of the school and college and even university students. So I'm not sure whether even 30 or 40% are able to attend all the online classes. So there is a huge digital divide, which one can see post-COVID. Apart from that, of course, tourism has started opening up, flights have opened up, but people who are a bit conscious, especially cities, are trying to be careful using their masks and trying to keep distance. But in many occasions, whether it's festivals or any markets, you will see a lot of people around, and then many of them may not be wearing masks also. So people are now becoming, coming back to kind of normal, even though the most important aspect of COVID-19 is something like, if you haven't observed and seen very close, you feel as if nothing exists. I mean, as if the whole pandemic is not there, it's somewhere far off. But the families which have suffered losses or deaths and have experienced COVID-19 and the way they have to move from one hospital to another, not getting beds, they have seen the death on the face. So it's extreme kinds of experiences with people across families. I think that is very important, which as an anthropologist I have observed.
Yeah. Thank you, Sunita. So given the time, I would like to ask a second question, and that is a little comparison between different health systems or health care situations in different countries. So I think that if I look at what the situation there is, there are in some sense, I think there are big differences in the systems, you know, between people. I mean, countries that are more developed can put, of course, more resources in the healthcare system. But surprisingly, this didn't work out in every case. So I think one surprise about the COVID pandemic was that the US, you know, who was always at the forefront of disease control, they had the first governmental center for that, and it was actually copied by the whole world. For example, even from China, but they didn't manage very well. So could you comment specifically on you know, on the or on the specific situations of the health systems in your countries, and how they coped with this surprising pandemic? So I would like to give the word first to Ronald again. Yeah,
okay. It's interesting. 75% of Brazilians depend on the National Health Service in Brazil. 75%. 25% have access to a health plan, which is kind of decent. Now, when the pandemic came out, there was a fear that the private hospitals were going to be taken over by the government, right? And so what the private sector did, they said, you know what, we will help the public sector. So those photographs you saw of the hospitals in the football fields in Brazil, those were all done by the private hospitals, just to say, let's, you know, leave us alone, you know, make sure that we have our clients here. Because if the private sector lost their hospitals, they couldn't really sell a health plan anymore. They would be, you know, overrun by the population, right? But one thing I think that's kept Brazil, to be honest, fairly, it's not good, but it's not a complete disaster as yet, in my opinion. Brazilians are very fearful. They know that their health system isn't so great, right? I think a lot of Europeans or even Americans think that they live in this great country and they have great healthcare and everything. Brazilians have no illusions that they have a good healthcare. So I think that has made them somewhat cautious. Maybe Japan or maybe America or maybe England or Germany, maybe. As Brazilians have the largest number of bulletproof cars in the world, right? There's no doubt. We have the most bulletproof cars in the world because we are fearful. And I think that fear has kind of braked, and not the craziness is kind of like, there's craziness, but there's some limits.
That's interesting. Yeah. Thank you, Ronald. Jane, do you have any comments on that?
Well, I think there's quite a range of opinions, but the mantra of Save the NHS actually meant that a huge amount of people were denied healthcare. Now there's just beginning to be recognised the excess deaths from cancer, heart conditions,
well, that's a good
so on, and probably increases in suicide. So we have the Nightingale hospitals, but I think they're being left empty, while a lot of my medical friends have just been very, very frustrated because they can't treat people. Partly, sometimes they are not allowed to treat them, and sometimes people are too frightened to come in, even with serious disorders. So I think Britain, unfortunately, has done a very good line in panic, whereas they used to be quite good at keeping calm and being practical. Perhaps contrary to the caution that Ronald was talking about. And, you know, turning the health service into an idol. It has to be protected, even to the extent of forgetting that the point of a health service is to serve people, not to protect the service.
Yeah, that is a good point, yes. And that's also a good point which you made about the side effects of the pandemic. So, we have to ask Nelson about that. You know, was the Kenyan health system overwhelmed completely, or was it somehow stable?
Yeah, I think the health system was quite overwhelmed, and particularly critical cases in major cities. I stay in the capital city. I think there was a time that it was not easy to get admission if the cases were critical and they needed urgent treatment. So the systems were overwhelmed because I think before that the preparedness levels were a bit lower. But the government has done quite a lot to improve the bed capacity, even in rural districts of the country. Because for the first time, we cannot have even our leaders flying out of the country to go and get healthcare service elsewhere. So I think that more or less reminded them that we need to improve the systems that we have. So a lot of improvement has taken place in that direction. And I think we are also having an advantage of the fact that we don't have many critical cases in Africa. I can't exactly understand why this, but we are not reporting so many critical cases. And
might be the age distribution, perhaps.
Most likely, yeah. Yeah, so probably if the numbers were as high as in some other parts of the world, then I'm sure we would have been overwhelmed completely.
Yeah, that is interesting. And Sunita, do you want to make any comments on the stability of the Indian health system?
Yeah, quick points maybe. When you look at, as I had explained in my presentation about the difference between the government and private sector, private sector has always been profit making, and many more corporate hospitals which have come in, they had displayed the huge rate list after COVID-19 for counseling or patient beds or ICUs. And in fact, a lot of them started telemedicine also because patients were not willing to come even for preventive checkups. And then like government hospitals, of course, were overwhelmed because then they were not having enough PPE and ICU beds, and the healthcare professionals were working without much of protection for themselves. So that was a sad state of affair. However, another very important aspect which could be seen was because most hospitals were converted to COVID-19 hospitals, a lot of patients who were non-COVID were suffering, and especially the chronic ailments, if they had to go for regular checkups, cancer treatments, they were suffering a lot. And finally, many people started doing home care or self-treatment because they felt if they have to go to any hospital, they should have at least 20 lakh rupees in their pockets. Otherwise, it was very difficult to get treatment. So a very discouraging picture at many times, but at the same time, governments were trying to say monitor and regulate the private sector, but it was not possible because all these years, many of these private sector hospitals have never been regulated well. So that dichotomy is always there.
Yeah, thank you very much, Sunita. So now just a last quick question at the end to everyone. And that is, when do you expect that the vaccination that is now going ahead in some countries already now in December, when do you think there will be an observable effect in your countries? So I would like to ask Ronald first again.
Bravely, September. September
2021.
2021, of course, yes. 2020, September, thank you. September 2021 as a number.
So relatively late.
Yeah.
And do you think Brazil will reach herd immunity by then? Or is it?
Yes.
Yeah, you think so?
Yes, unless some disaster happens, which is obviously possible knowing this year. Yeah, I would say around September, yeah.
So in general, Brazilians will take if they can, they will vaccinate.
According to the surveys in the world, yes, Brazil is one of the countries in the world that are quite open to the aspect, apparently, if you believe. Yeah.
Interesting. Okay, well, we check on that at the time.
With a betting pool going on here, Anyway.
Now, Britain was the first country in the world that started the vaccination. So what is your expectation, Jane, in Britain?
So yeah, they've started. I know people who've been vaccinated. I've got a student who's in a voluntary organisation, St John's Ambulance. They've already been trained, and they're expecting to set up 2,000 vaccination centres around the country. So I'd imagine it depends on the supply. I think it's quite likely we might start seeing an effect January, February time.
Yeah.
I mean, not necessarily, you know, it might be difficult to distinguish from the natural sort of peaks of winter and summer, but they're certainly trying to roll it out pretty rapidly. So I think we might see something quite quickly. And I think the army's all being trained up to give vaccinations as well. Maybe we won't be able to get 1.5 billion syringes though.
You might, so there might be other limitations, not the vaccine itself. But okay, so that's a very optimistic forecast. But let's see. So we will discuss that then in February. What do you think, Nelson, in Kenya? What is will there be? I mean, I guess there will be not the AstraZeneca vaccine, so it might be a bit delayed until all the other vaccines that don't need this this very severe refrigerator. So when do you think there will be an effect measurable in Kenya?
Yeah, I think the effect might be measured later next year because they are planning that if the vaccine is finally through all the stages of clinical trials, then they could adopt it anywhere from February onwards. And the recent announcement was that come February, if the phases of clinical trials for Zeneca are through, then they could be able to probably begin to take it up, but in small percentages so that they deal with the risk groups, maybe the elderly, maybe the teachers, maybe the police, people in the police service, and these kind of groups that are quite exposed. But then later in the year, they can also upscale and give it to the population.
Yeah.
But I think they're also still waiting because it is on the third phase of the trial, I think what we understand.
And do you know whether Kenya is part of this global distribution program that has been put into place? I think you know, several countries are participating, and also I think the Gates Foundation is also one of the members of this global alliance in vaccine distribution. Do you know anything about that?
Yes, I think I read that, but I don't remember exactly the body that is trying to support. It could be what exactly you are explaining, but Kenya is one of the signatories. So yeah, I think at some point there were about 39 countries that had requested for that support when it starts, and I think Kenya had also signed to be part.
Yeah, because it was interesting what Chris Bauch said at the beginning, that Canada actually has too much, has bought too many doses, jabs of vaccine. So I guess the distribution problem, the worldwide distribution problem, I guess, will be a problem.
Yeah.
And Sunita, what is your outlook for India for the vaccination strategy?
Right. As I had shared that already there's a well laid out plan in phased manner whom they want to administer first. And I see that it will start very soon, but it may take some time because there's a huge population, and phase-wise they will be giving to people who need much more, like healthcare workers first, and then maybe older patients, and then those who are already suffering. But then we are not sure how many of the younger population are willing to take unless they have seen death very closely and they want to take a vaccine. But we are not really sure about the normalcy, because recently one of the IIT Chennai was opened up, and almost like 300 students got COVID positive. So that's the reason why I think even now educational institutions are going to be closed for some time.
Mm,
I'm not really sure, maybe 3-4 months till we, can get back to normalcy.
yeah.
It's very uncertain as of now.
And which vaccine is discussed in India? Which ones of the 4 or 5 that are currently?
Not really sure, but something related to mRNA. That's what, because I'm not following on the vaccine part. Really not sure about it.
Okay. Well, thank you all very much. So I would now like to go into our last phase of the discussion for a few minutes, and that is a general discussion and general experience by everybody. So I would now like to ask everybody being here, to share questions, observations about this year. Yeah, you can just use your microphone. I think that would be the best strategy. So is there anything you would like to add to our questions, or is there anything we have left out in your opinion which needs to be discussed? Yeah, it's always a sudden change in the discussion. I know you have to be prepared, but let's maybe,
I have some question.
Okay. Yeah. David?
Yeah. I was really surprised by Sunita's talk when she was talking that there is this app that has been massively downloaded by people, and because since the very beginning we thought, maybe everybody thought, that apps and IT technology could help very much into containing the epidemics. And in reality, this has not been so. Apps have failed to make any impact on the containment of the disease. And one of the reasons precisely is because it's very difficult to make everybody download the same app and use the app accordingly and consistently. So do you think this there in India has been different? So what's the impact on the use of the apps and so on in the containment of the disease?
Yeah, thank you, David. As I said, Arogya Setu app was made mandatory to download, and especially if you are on move, like if you, after the unlocking started, when you start going out, and especially if you're traveling to other states, at the airport, they'll check whether you have downloaded Arogya Setu app. And it is like a self-declaration. When you download the app, you have to fill certain information about your symptoms and whether you have been tested positive or if you have even gone for any testing. So if you are positive, then you have to say yes. So that actually indicates for anybody around. So if I go and look into my app, I can say, okay, a positive case is say 5 kilometers away or 3 kilometers away. So then that will help you to not move around those spaces. So there was a lot of advertisement, lot of making it more mandatory. But then that doesn't really, documented as to how it has impacted. But using apps and using of GIS was very useful in states like Kerala. They could really track the patients who were having COVID positive. They were trying to make them confined to their homes and do all the quarantine, and also providing them whatever is required. So some states could really use these apps for the benefit of the patients, helping them to quarantine, helping them to send ration to their houses. But as I said, real data to see the impact of using this Arogya Setu app was not really measured. But downloading was done almost like many. In fact, I don't have a concrete data on that, but it's been said that it has been downloaded maximum. because even the government wanted that, and everywhere they can check. So that was the fear, because now a lot of fines are being added. Like the latest is trying to keep the mask, and sometimes it's quite ridiculous that even if you're going with your own family in the car, all 3 or 4 of you have to put the mask, otherwise the cops will stop you, and they were fining rupees 500. Now they have increased the fine to 2,000 rupees. So some very strict rules have come up so that people maintain these masks, especially in urban centers like Delhi. But it's not the case in many other places.
Could I just clarify one thing, and that is, you said the Indian app also has has GPS data on it, because in Europe that would not be allowed. It would be against data protection.
True,
So,
true. I mean, there's been a lot of debates and discussion about infringement into privacy of people, because the moment you start downloading the app, you have to put your location on, and then anybody can be traced. And I mean, last few years there've been so many new developments about different laws which are coming, and even the one card, and even making Aadhaar card as a unique number mandatory for people. Not everybody wants to do, but then now all the Aadhaar cards are linked to your bank, so it's easy to trace your movements and also your account. So in one way, it is argued that having one unique number, and so that will cut down on the, say, black money or trafficking, misuse of money and things like that. But at the same time, there's another argument saying that it's too much of infringement into your personal life. If you're using your GIS, if your locations are known, if your movement is traced, then it's easy to target people, and especially with minorities, and also the issue of the border state and people coming to India and settling. So the whole case of Rohingya movement of people to India. So easy to target people. So that's the reason why there's been a lot of protests and resistance, even to download some apps on sometimes to not get the Aadhaar card. But for all those who are using the public distribution systems or government services, it becomes very mandatory to have your Aadhaar. And because without that, you can't link your banks, you can't use the banks. It's very mandatory now.
So it's a kind of identity you create there. That's very interesting. So there is a trade-off between data protection and well, the advantage of knowing who is infected around you. Are there any other questions? Also about the other topics we discussed today, so you can now switch topics. That's not a problem.
Marcus?
Yeah.
Well, just an observation. Unfortunately, I joined the meeting a bit late. I'm sorry, and apologize for this. But I was really interested by the observation that Sunita made in his talk when she was talking about the issue of somehow the fact that the pandemic is actually realizing one of these conditions that Naomi Klein described in his shock doctrine in her book. Sorry, in her book. So yeah, I'm kind of. I mean, I had the same impression here, and I mean, my general observation is that we should somehow, internationally speaking, be very aware of the fact that these new conditions will be somehow used to push certain agenda. And we actually, I think, and I hope that the majority will push somehow a more I would say, not popular, but more civic agenda, namely, for instance, the crucial importance of the national health systems, basically everywhere. That's clear now that all the countries that had a national health system manage a bit better than the others. It's very evident, I think, to me.
Well, I think Ronald might contradict that. In Brazil, there was it was more the other
The other way around.
Was it Ronald?
No. I disagree. I agree with you that saying that Brazil has a national health system of 75%, which is like an Obamacare sort of thing.
Oh.
Very shoestring budget, huh? Trust me, very shoestring. But it's really any Brazilian can go and get treated for anything, from stents to transplants to anything, maternity, of course. And it worked. It kind of worked, to be honest. The case fatality rate has been impressive, given the limited resources. Very limited resources. I think I agree with him that I think countries that have shown a national health service seems to have done a little better. Now, I remember I made a point. Brazil has a safety valve, which is putting a bed in a football stadium. So that, I think, was a big help for Brazil. We're able to do this, which Europe do that.
Yeah.
So that means that in any case there should be some sort of general system that is able to help out basically everyone, right? That's the point. You need some sort of relation between, if you want, the private sector and the public sector. And this general sort of connection, it's clearly run by the state. It's obviously have to be run. I mean, it cannot be run by private companies, right?
Yeah, but I think you are absolutely right, Luca. But we had, if I remember today, we had 2 examples of national health services which were run down by their governments, because the problem is a little bit that if you have a national system, it's easy to save money in a sense, because people first don't realize, and then it's getting more and more severe over time. I think that's what happened, for example, in Britain, for sure, in some sense, and maybe also in Kenya.
You mean that governments used to somehow cut on national health systems?
Yes.
But now the pandemic is actually showing that that's no longer possible. I mean, it is possible, but can be extremely dangerous for the population, right?
Yeah, I think it's the following effect. That's what I read, for example.
Yeah.
I think it was in an article in The Economist. So the situation, for example, was like that the national health services were not funded so much because the elites usually, the people with higher income can go to a private, policy
insurance and
and insure them. So they are separated from that. But you are right, Luca, because the pandemic is something you cannot fight if you are going to your private hospital or so. If you go around in the public, you are vulnerable because anybody can be infected. And so I think you are right in saying that it has changed the minds of many politicians. That
I mean, that's I'm not completely sure that changed the mind of many politicians, because there is no, somehow internationally speaking, this is not very clear. I mean, it's clear to the people. Let me use this word, right? To the many, but somehow in the public discourse, this is not really an issue somehow.
I agree with
not
you.
now.
Actually, very important. The dichotomy between public and private sector has been much more pronounced after 90s, after health sector reforms. And the health policies have also been very pro-private and corporate sector. And that's where some of my research on medical tourism, I could see that we have equipped ourselves so well in the private and corporate sector that we are treating patients from other countries. But our healthcare services, public healthcare services, are really in shambles, where even the basic medicines are not available, because the funding is so less and we are not increasing the budgetary allocation for these public sector. And there's been always a push from the private sector, because most of the owners of the hospitals are in the decision making, on the policy making. And many of these hospitals have changed their nature. That's another article we have written about. Not anymore the doctors are like, there are few doctors, well-known doctors, who own the hospitals, but more and more hospitals are now business houses. So businessmen, they hire and they even fire the doctors if they are not bringing business to the hospitals. So pandemic has actually opened up the whole for the public to see. It's been there, but it was not very visible till we were studying. And there was a lot of these private hospitals actually remove the staff and the contractual staff. They are paid very less. Only the few hand-picked doctors are given 4 or 5 times the salary of government doctor. But all the nursing staff, young doctors are not paid well. And as I said, it all runs on the profit margins, and the MBA graduates are the ones who are running the hospital. So huge problem over there. And we've been writing on that, but not much is happening. In fact, for COVID-19, I had written an article, and one of the most critical journal, the Economic Political Weekly, is not yet published our article, which looks at the private sector and the role of private sector during disasters. So we haven't got any confirmation from them that they are going to publish it. So that's what the state of.
So, Sunita, excuse me, you have this federal structure, right? So all the states are somehow, they have a large independence, right? So can you tell us about, this type of attitudes toward the public sector? Is it equal in each state, or there are differences?
No, as you rightly said, health is a state subject. So most of these states have their own healthcare services. There are some central government programs which run, but then some states have good healthcare facilities and infrastructure, especially in the private sector, like southern states and few states in the north. But these states like Bihar and Madhya Pradesh and many northeastern states don't have tertiary care, much of tertiary care. So they all stock up to the, come to the metropolitan cities. And that's where initially there was a say that All India Institute of Medical Sciences in Delhi is one of the premier public institutions. So such institution should be developed in all the states, but so far it's not there. So most of the patients travel all the way from other states to Delhi, or if they are in the southern parts, they'll go to Chennai or Bangalore or Hyderabad. So some states, some hospitals are good, but many of these private sectors are there in many big cities. But some big states which are really backward, they still lack good healthcare services. And the Northeast, as I said, 8 states in the Northeast are really neglected, and they don't have really the super specialty healthcare facilities.
I see. Thank you.
Very, very interesting.
Yeah.
Is there any other comment or question you would like to make? Yeah, well, maybe it's time to close then. It was a long day, but it was extremely interesting, and I really would like to thank everybody for contributing. And yeah, let me say though, the year is ending, so I wish everybody good luck in 2021 if we don't see each other. And yeah, keep healthy.
And
and
some of us will enjoy celebrating Christmas.
Yeah.
Merry Christmas.
Bye.
And Diwali.
Yeah. Bye, everybody.
Bye.
Yeah. Thank you
Bye,
very
everyone.
much.
Bye.